on management of blunt trauma. Now, it's not a comprehensive, this is what you must and must not do, but it just gives you an introduction to to how we manage some of the commoner injuries that we deal with in particularly UK practice. Now, there's difference in the international spectrum of trauma. You're going to get a lot more penetrating injuries in the United States, for instance. Predominantly in this country, we're dealing with blunt trauma, road traffic collisions, things like that. Let's just get my... So, particularly the solid organs, such as liver, spleen, particularly prone to injury following direct blunt trauma. Ones you've got to be careful for are the deceleration injuries. So if you're in a car and you come to a sudden halt very quickly, obviously there's bits of your body that are relatively fixed and bits that are relatively mobile, and they are prone to injury. And some of those signs can be subtle and potentially devastating if you actually miss them. Overall, in trauma, the management decisions are relatively simple, but the decision making is important and it can be quite difficult. And also, anatomy is important. Now, those of you who've seen some of my webinars before, some of my lectures, know I'm a bit of an anatomy nerd. It is actually important, you know, and if you want to pursue a surgical career, it's always useful to know where everything is if you're going to take it out or move it around. So just in broad principles, we all know about dealing with acutely ill people, ABC assessment. But major trauma, remember, it's CABC. So the control of catastrophic hemorrhage comes first, because there's no point securing an airway if the patient's going to bleed out in front of you. Beware the stable patient. Okay, now there is no suitable definition of a stable patient. So what is stable to me will be something that is completely different to Chris, will be something completely different to whoever you're working with. Okay, and also we may have to go straight to theatre to deal with any injuries, blind, or perform something like a resuscitative thoracotomy to get proximal vascular control. Again, in the UK practice, we don't do that a lot. In the entry here, we do that about 12 times a year overall, and the outcomes aren't good. Always beware of seatbelt bruising. That usually indicates significant force has been applied to the person. And these are the patients that will develop, you know, problems from occult injuries that you've missed. So my basic decision outline is you have your trauma, you are either stable or unstable. If you're unstable, then you need something doing, fairly straightforward. If you are stable, then imaging is always useful. Okay. Again, that depends on your local setup. Our trauma bay, our CT scanner is about 10 yards from the trauma resuscitation bay. If you're having to go to the other side of the hospital, that may alter your decision making. And once you've identified your injuries, we either manage conservatively, so this is selective non-operative management, or SNOM, or do something. Now, doing something may involve interventional radiology, which is very good for things like pelvic injuries. Some visceral injuries we would deal with that way, or proceed to surgery. I put FAST in, which is focused abdominal sonography for trauma, just as an aside, because again, we don't use this a lot, certainly not in the entry. It's highly operator dependent. Takes a fair amount of experience to get good answers. And a negative scan does not mean you have no injury, right? But we don't use this, certainly some centers use this quite a lot. We don't use it a lot in the entry. I've just kind of put that in just as a sort of an aside there. The first major injury we deal with is the liver. Now, basically, if you consider liver liver is just a big venous bag, okay? It's a high flow, low pressure organ, okay? If you actually look at hepatic arteriograms, the arterial supply of the liver is very small in comparison to the portal venous flow. And frankly, most venous bleeding will stop eventually. okay, either spontaneously or in major injuries when the patient exsanguinates. So therefore, you've got to do something. So that dealing with liver injuries, we've got to accept that they are very common. They are graded, and I'll go through the grading in a minute. But low-grade injuries rarely require intervention. These are the ones where we observe, and it will settle down with very few subsequent complications. Interventional radiology, certainly in my experience, is rarely helpful for liver injuries in the acute setting, because most of the bleeding you're dealing with is venous, and you can't embolize big hepatic veins. You can get into the arteries. I say this, but last week we had a chap who suffered a crush injury and actually tore his left hepatic artery, which was a slam dunk for embolization. So we do it, okay, but it's not that helpful a lot of the time. It is, however, good for pseudoaneurysms. Okay, so if you have a liver laceration, certainly the protocol here at Aintree would be we repeat the CT scan in arterial phase about 2 or 3 days down the line, looking for any arterial pseudoaneurysms, which then can be embolized, because they will rupture eventually if you're not careful. Everything these days has a grade, okay, so and that includes livers, and most of the trauma grading comes from the American Association for the Surgery of Trauma. So they've got grading schemes for everything. So in this scheme, you can see that grades 1, 2, 3, okay, so subcapsular hematoma more than 50%, or laceration greater than 3 centimeters. Now, these will more than likely be managed conservatively if we see them. We will even manage grade 4 lacerations and injuries conservatively. Grade 5, you are probably going to be faced with an unstable patient, and this is where you've got to think about surgery. And grade 6 is probably a life-ending event. You have basically tore your liver off the vena cava, which is never going to end well for anybody. Now, the basic principles of liver injury are the three Ps. There are 2 more which I will go into, but the basic principles are the 3 Ps. Remember, it's a low pressure system, so you press on it, back it, and then we have the Pringle maneuver, which everybody knows about, hopefully from your anatomy days, but we'll go through. So pressing and packing basically come together. You make a big hole, get to the organ, take down the falciform ligament, and again, there's some disagreement about whether you should fully mobilize the liver or not. I personally wouldn't, because if you do have a major venous injury at the back, if you take down all the liver attachments, you're going to be in big trouble very quickly. And basically, you squeeze the liver back together and make it look like a liver, and then surround it with packs, okay, to hold it all together. And that will control most sort of liver trauma that we would see, certainly in this country. If necessary, the packs may be left for several days. You can close the abdomen temporarily, leave the packs, take the patient to intensive care, stabilize their physiology, then bring them back at a later date. And I'll be going through this in the next webinar in a couple of weeks around damage control surgery, damage control resuscitation. Basically, you press the liver back together, press on it, and you pack it, and that will deal with a lot of bleeding. Again, there are other tips and tricks for severe injuries, a little bit out with this webinar, but they're the basic principles. So now we've got press, pack, and there are 2 more Ps. Okay, now I claim no originality for this. I ripped this off a trauma sit, one of the colleagues from Glasgow, from one of his presentations, and I thought it was quite neat, so I thought I'd steal it. So the 4th P is picture. So here we have a hepatic angiogram, and here we have a pseudoaneurysm within the right lobe. Okay, so this is your picture IR. So if you're in trouble, then interventional radiology may help. Okay, and your last P is the peek and shriek, when you take the packs out too early, start swearing, put the packs in quickly, and then leave it for a longer time. Okay. So they're the P's of liver injury. Now, the Pringle maneuver basically is a maneuver which relies on a little bit of fortunate anatomy. Basically, it's to control all the vascular inflow into the liver. Now, if you remember your anatomy, the hepatic artery and the portal vein both lie within the free edge of the lesser omentum. And if you want to know the embryology, again, I did a webinar a couple of years ago, which you can still access on the college website. And it's basically because the liver forms in the ventral mesentery of the foregut, and that's the edge where the vessels run. Okay? It's very quick to apply. Once you're in the abdomen, you can get your fingers round into the foramen of Winslow within a matter of seconds. You can grasp the vessels, so therefore you've got complete vascular inflow control to the liver. Right? The question then is, what do you do next? Because you can only do this, keep this applied for about half an hour, 40 minutes, according to the liver surgeon. And then you've got to do your packing and all the other stuff, or any other little tricks to stop the bleeding. Okay, so you can get the Pringle on, deal with the liver, and then take the Pringle off. You can't leave the Pringle on because that will sort of vascularize the liver. If you apply the Pringle and the liver is still bleeding, you are in big trouble, because that implies you've injured a major hepatic vein or possibly the retrohepatic cave. If that happens, again, there's an old adage in trauma surgery: there are more ways to deal with this injury than actual survivors. Now, we've had one survivor here in Liverpool that I know of from this sort of injury, and it took right hepatectomy to get to the injury. Right? And we've got some very good liver surgeons here with us, and it moved quite quickly. So we literally took off the right lobe of the liver to get to the vascular injury at the back. And fortunately, he survived. Moving on to the second commonest injury that we see, the splenic injury. Again, it's a solid organ injury that often requires intervention. Now, we intervene on spleens a lot less than we used to because we are becoming a lot more comfortable about non-operative management. Certainly within stable patients. Again, you've got to be careful of your definition of stable, but these patients can be managed conservatively. And there is a greater tendency to do this in children, even if by adult standards, the patients are unstable. Again, the pediatric surgeons tolerate a greater degree of scariness. You know, they would leave a spleen where I'd probably end up taking it out, and they seem to do all right. We can embolize the main vessels, either segmental or main splenic artery, or we can take the spleen out. It's just kind of stuck on the end of the pancreas there, so it's relatively straightforward to take out. There's a lot of talk about the role of splenic preservation in major trauma. My personal feeling is that if you have a patient who has got multiple injuries, splenic preservation is not something you should be worried about. If your spleen needs to come out, it needs to come out. And there's a military colleague of mine just kind of said, well, the best way of preserving a spleen is formalin. All right. So again, you don't want to be messing around for hours on end trying to preserve a bit of spleen when you've got a patient who's had polytrauma, they're cardiovascularly unstable, they're hypotensive, they're acidotic, and things are starting to go wrong. It's best just to take the spleen out and be done with it. Again, the old American Association of Surgery of Trauma comes in with the grading 1 to 5. Again, most of the ones want grade 1, 2, up to about grade 3 in some cases. We will probably manage conservatively. Grade 4 generally, and grade 5 virtually always needs something doing, either interventional radiology or surgery. And this is a couple of scans. So here on everybody's left, you see here, this is the spleen here, I'm just highlighting that, and we have a big laceration going through the spleen. We've got some surrounding hematoma, and we've also got a lot of free blood within the abdomen. You can see that around the liver. Okay. Whereas over on this side, what we have is that we have again spleen laceration, fairly well localized hematoma here, but we've also got this. Now you can tell this is an arterial phase scan because the aorta is lit up. Right now, if this was venous phase, that would be a bit duller. You'd still be able to see the lumen. When it's bright like this, these are arterial phases. And here we have an arterial phase blush, and this is active arterial bleeding. Our hematoma is still relatively well localized. First case here, my decision making would say probably go to theatre. This case, well localized arterial bleed, would probably go for IR. And this is my decision making tree. Now, again, there are guidelines around splenic injury, and again, it's the American Association that put them out, but they are quite woolly. And this is my personal decision-making tree. Now, there are colleagues in my unit who would disagree with this, but this is, in my mind, is safe, and kind of where I go. So you have a possible splenic injury, you are unstable, okay, you can't get the CT scan, you need an operation. Discussion, end of. Okay. You're stable for CT. Again, that goes back to deciding what is stable for you and the unit you work in. You get your imaging, confirm your diagnosis. So again, like I said, you have a localized hematoma around the spleen. Okay. Patient's relatively okay, behaving themselves, and that's one for the selective non-operative management, SNOM. Okay. Bearing in mind that these patients need to be watched closely. Now, some units would immediately admit them to crit care, high dependency unit for very close observation. We have a very good major trauma ward here in Liverpool, so we admit them there. They need to be watched very closely for a number of days, because these guys can be spontaneously burst the hematoma. In fact, when I first qualified, my first case of a patient going off on me on the ward was a ruptured splenic hematoma about 5 days post-injury. So it does happen, these delayed ruptures. So be very wary. You know, these guys have to be watched like a hawk, because they can cause problems. If you have a localized hematoma with an arterial blush, then again, interventional radiology. But it depends on your local arrangements, okay? Not every hospital has access to interventional radiology. You may need to think about transferring the patient. You need to know what your local arrangements are, and maybe that actually these patients end up with splenectomy or surgical intervention. Again, it depends on what your local centre, what your local pathways are. If you have a lot of free blood, then in my mind that equals an operation. You know, that means you've got a significant splenic injury, which will, it's probably not going to settle spontaneously, and that would equal an operation. And again, like I said, that's my decision-making tree. Again, people would disagree with it, probably quote some evidence, but actually, if you look at the guidelines and the evidence, it's all a little bit woolly, and a lot of it's open to interpretation. So if you're going to do a splenectomy, again, back to our anatomy, the key is dividing the peritoneal fold between the spleen and the kidney, the linear-renal ligament. That allows the spleen to be drawn to the midline. It makes life a lot easier. Okay, be done very quickly, and often it's just a case of nicking the peritoneum and just bringing it just packs behind it and dealing with all the little bleeders afterwards. Okay, so you can do this very quickly. Be careful of the short gastrics. Okay, remember they come off the splenic artery and they go to the stomach. So there is a small risk of stomach injury or stomach necrosis in splenectomy. Always leave a drain in trauma splenectomy, because there is a 30% risk of a pancreatic fistula. So leave it in for a few days. If there's any worry about what's coming out of the drain, test the amylase. If it's above about 300 or 3 times your normal range, then you've probably got a small pancreatic fistula. Because as you can see, the tail of the pancreas often sits right up against the splenic hilum. And again, the reason you get fistulas is because if you've got big hematoma or a big laceration, you quite often can't really tell what you're cutting through, right? So again, you've just got to deal with the problems as they come up. So you do accept that there are potential complications. And the one to remember is your post-splenectomy prophylaxis. Now, again, that guidelines change pretty much weekly sometimes in my mind. Again, at the moment, we're giving amoxicillin for 2 years and regular and annual vaccinations against capsulated organisms, so Haemophilus, pneumovax, meningococcal C. But again, each individual centre, each country is going to have their different post-splenectomy prophylaxis regimes. Moving on to our last area, okay, which I mentioned was bowel injuries. Okay, now these can be due to either direct compression, bursting, or shearing deceleration. So injuries tend to occur where a structure transitions from something relatively fixed to relatively mobile. So things like the gastroesophageal junction, BJ flexure, roots of the mesentery, right? Small bowel, sigmoid, right colon. Okay, so where the mesentery comes off, where its attachment can be prone to avulsion. Okay, as can also just rip the bowel off its mesentery on its own. All right. So these are the injuries which, if you're not careful, you will miss and can cause a lot of trouble, because the bowel becomes devascularized. It may actually be torn open. Then you get contamination of the peritoneal cavity, ischemic, necrotic bowel. Patients become very sick very quickly, again, if we miss them. And we still miss them even here. We're very much more in tune to the fact that they can occur. And some of the warning signs are here. So again, first patient on the left. Here we have a young guy with what appears to be an isolated hemoperitoneum. Okay. Liver looks nice. Nothing obvious with the spleen there. Couldn't really see anything else. A lot of blood in the abdomen, no particular reason for it. Operation, he's pretty much tore his right colon off for its attachment. This happens because certainly in some people, the right colon is actually quite mobile and it almost is on a mesentery. He had an ischemic right colon. He had a right hemicolectomy, did very well. This one here, on your right over here, this one is very subtle here. So all you're seeing is some mesenteric stranding. Okay, again, not very obvious, and he had a little bit of slices lower down, had a little bit of blood in the pelvis, but he was very, very tender. Again, this is a chap who came off a motorcycle at very high speed, unstable, so we took him for a trauma laparotomy, and he'd avulsed his sigmoid mesocolon and tore his sigmoid, the circumferential serosal tear of the sigmoid, and he ended up with effectively a Hartmann procedure. I think we're coming in back in a few weeks' time, actually. These are particularly these ones here. These mesenteric injuries are very subtle. You have to be careful, and if you've got any doubt at all, always have a look. Nobody will ever blame you for having a look. You'll blame for not having a look, but always be very suspicious. So, like I said, this was only going to be kind of a broad hop, skip, and a jump through some of the commoner injuries. Most of our patients are managed non-operatively. Again, in the United Kingdom, most of our trauma we're dealing with is blunt trauma. Most patients do very well, right, because we just observe them, and like I say, most of them will do fine. Unstable patients, you've got to do something. You can't leave somebody with either as a transient responder to resuscitation or who's unstable. Okay? The basic principle is keep it simple. Okay? You don't have time to be all clever stuff. Stop the bleeding, control contamination, and get the hell out if you need to. Okay, and again, that's kind of the principles of damage control surgery, which we'll be going through in a couple of weeks' time. The other thing to be aware of is your local setup and your local pathways. Certainly in England at the moment, we have the major trauma networks. So Aintree here now is a major trauma centre. We have a dedicated visceral trauma rota with specific trauma surgeons. Again, depending on where you are, even in the United Kingdom, Wales and Scotland are just getting the system up and running. So again, you've got to be aware of your local setup and local skill sets, local facilities. You also have a high index of suspicion for occult injuries, particularly in high velocity trauma. So high speed road traffic collisions, seatbelts can they save a lot of lives, but they can actually do a lot of damage. Okay? But if you think there's a problem, there probably is. Okay. If you're interested, okay, this is the Bible of trauma surgery. Every single trauma surgeon I know has a copy of this pretty much close to hand, okay? I have no financial interest in this book whatsoever. I'm on my second copy. I wore out the first. Okay? It's Top Knife by Hirschberg and Mattox. Okay, it's about £25. It's on Amazon. It's a brilliant read. You could read this in a night. It's very well written, and it's basically top tips on what to do and, more importantly, what not to do. Okay, but if you're interested in trauma surgery, I'd highly recommend getting this book. Okay, you'll just keep on going back to it. We certainly do. Usually 2 o'clock in the morning. So okay, so
brilliant. Thank you very much, there, John.
Questions?
I do have a few questions. I think
Yeah,
I don't know
sure.
if you can answer as well. I'll just start from the top, just running through these. So the first question would be from what should be the plan for a stable pregnant patient with blunt abdominal trauma? Would you proceed with no imaging at all, or risk putting them through an MR?
Again, a lot of it depends on multiple factors here. You're thinking about mechanism, are there any external injuries, all that sort of thing. Again, it depends on your stage of pregnancy. So once you're beyond the first trimester, when everything's kind of there, then it's a risk benefit of what do we do. Trauma MRI, again, our MRI scanner is the other end of the hospital. So I've got to think about, is it worth taking the patient down there? What is that going to give me any additional benefit over just going through CT scanner? And so a lot of it's based on clinical, on the clinical thing. And the other thing to bear in mind is the potential injuries to the baby. We've certainly had a case here where the mother was perfectly fine, absolutely no injuries whatsoever. Unfortunately, the baby died due to quite a significant car accident with, I think, a falling tree or something. We've certainly had that here in Liverpool, where the mother's been fine, and then unfortunately the baby didn't make it. I think it was probably a placental avulsion or something like that.
Yeah.
So a lot of it's based on individual circumstances and again, local setup.
Sure. Another question is, if you leave the packs in for several days, have you ever known of a case where they've developed staph toxic shock syndrome?
I've never heard of it.
Me either.
Yeah, I suppose it's theoretical, but certainly if you take your packs out too early, you're going to get that peek and shriek scenario. Or you're going to the anaesthetist is going to start swearing at you when they start having to squeeze the blood in. So again, I've left packs in 3 or 4 days.
Me too.
It's difficult to get them. Sometimes you've got to be careful when you take them out because they do become adherent tissues. So I try 24, 48 hours, kind of my top end. But I wouldn't have any sort of aversion to leave them any longer. But again, if you're leaving packs in longer than 3 or 4 days, then you've got to question what you're actually trying to achieve. And again, if you're leaving abdomens open in that time as well, and again, there's ways of managing open abdomens. You've got to worry about would you be able to close them? So I personally try and get everything closed and tidied up by about day 2. It's driven by physiology.
Sure, absolutely. So another question is a transplanted kidney particularly susceptible to blunt trauma given its location, or have you not noticed any particular extra risk?
That's a really good question, and I have no idea.
I've certainly not noticed there being any extra risk to the transplanted kidney, to be perfectly honest.
I must admit, in the 6 years I've been at Aintree, I don't think we've ever, I certainly can't recall a transplant patient being involved in a major trauma. Not clearly happened.
And it tends to be blunt trauma from the lap belt across the hips rather than anything else. But again, it's not particularly usually a major issue. And I'm not really lose a kidney because of it.
Yeah.
Okay. Somebody's asked, would you kindly explain what is included in your SNOM?
Observation, serial observation. Keep an eye on the blood count. Regular, it's just basically regular clinical observation. And certainly, if we're doing livers and spleens, we'd always kind of rescan them at about day 2, day 3, looking for pseudoaneurysms. So there, what's happening there is you have a contained arterial injury to the organ, which will start to expand. You will get a kind of an expanding pseudoaneurysm, and that will rupture at some point. So we'd always re-image at about day 2, day 3, primarily to exclude pseudoaneurysms. But other than that, it's just serial clinical observation, regular blood pressure, pulse, bloods, and just watch and wait. And the vast majority, nothing will happen. You just have to be wary that there are potential complications that can happen a few days down the line. We do tend to probably keep them in about 4 or 5 days. Again, there's probably there's no particular evidence or guidelines for that. A lot of that is my own personal adverse experience, because like I say, I have seen somebody blow a hematoma at day 5. That was my very first experience of a splenectomy.
Yeah, and again, I mean, there's another question about after 1 to 4 hours after injury, but typically it's not 1 to 4 hours. It's usually after day 3, 4 that they start to have.
It's usually when the hematoma starts to liquefy, and it draws water in, expands. It doesn't actually, you haven't got a secondary bleed. It's just the hematoma expands because it's liquefying, and then it tears if it's contained within the capsule, it'll tear, and then you bleed.
Sure. I've probably got time for 2 more questions. I've got one question about how would you manage blunt trauma to the ureter? It's not something I've ever come across, I'll be honest. It's
tucked around the back, so often we don't. Again, it's something kind of within the renal trauma, and again, we tend to manage a lot of kidneys, or even more so conservatively, because again, as long as your renal fascia is intact, you can pretty much manage everything apart from avulsion of the kidney conservatively. We very rarely do much with the kidneys. I guess blood trauma, you're going to get potential contusion, bruising of the ureter. You probably just manage them conservatively and see how you go. And if it obstructs the kidney, then you just have to, I guess, stent or nephrostomy. Again, it's not something we see a lot of.
Now, finally, just one last question. I'm sorry, there's a few that I haven't had to answer, so I apologise for that, but we're a bit limited for time. But there seems to be an ongoing topic about bowel injury and non-operative management for suspected or possible bowel injury. What would you see as the typical course for a patient if you miss something, or even though you have a high suspicion, think you can possibly watch and wait?
The ones, and I'll hold my hand up. I've done it. We've all made the mistakes, and we've left. Oh, it'll be fine, and not. What happens? Certainly, what seems to happen is patient will, over a day or so, will develop abdominal pain. They'll become a bit more unstable. They become acidotic, and the lactate starts to rise. And there's no other particular reason that you can put your finger on. If that starts to happen in the absence of anything else, then you've got a bowel injury. You're mandated to have a look. So again, if you go back to the scan and you see some of that mesenteric swirling, the haziness, and after a day or so, they start, the lactate starts going up. They start complaining of abdominal pain. It's becoming well. That's the sign that there's a bowel injury. And again, you do that. My personal take on that, it's a lot of that is your clinical. Your clinical take on it. You know it's a possibility. It's in the back of your mind. Something's gone wrong. It's going to be something like that. So that's the kind of the warning signs for me.
Sure. Right. Well, thank you very much. I'd just like to bring that to a close, and I apologise. We're just getting like 10 questions in at the last second, but we are short of time. Apologise from that perspective. Thanks ever so much for your really interesting talk today. I know it's a little bit of a global look at things, and there are lots of minutiae that people are very interested in. Can you recommend any further reading that you would look at, or other than your Bible,
let's say Top Life is a really good one. Let's see. Well, I've got some on the shelf. There's a very, if you can get hold of it. Oh. Does anybody see that one? Trauma surgery by the orthodontist. Again, this is another tips and things to do. It all goes wrong at 2 o'clock in the morning. But so overall, you know, there's a few of us as well. The main atlases of, again, there's this one by it's an American atlas. That's that's a good atlas on cadaverous, and you know, that's kind of how it's doing as well. So that's another good one. Top Knife is by far it's the easiest read. It's also the cheapest. You know, and you'll get a good idea. And obviously, you have your ATLS training. And there's no real substitute for actually doing it and being part of the trauma team.
Brilliant. Okay, just on that last note, thank you very much for your time, and thank you everybody for attending today and your very interesting questions. We could go on a long time with these, but we'll obviously have to move on. But thank you very much again.
Okay,
and I'd like to say